You're listening to Don't Tell Me to Relax, the award-winning, no-nonsense, always friendly, down-to-earth fertility podcast. I'm Hannah, a fertility acupuncturist and big believer that fertility care and education should be better. Each week, I sit down with a guest to share real stories, advice, and honest conversations to help you feel better informed. And for care and connection, we have our Don't Tell Me to Relax online fertility community and our clinics in London and across the UK. To find out more about getting involved and working with us, the details are in the show notes. Don't Tell Me to Relax is proudly sponsored by the lovely people at Acupips. Acupips is the original ear seed company founded by acupuncturist Zoe Young. Ear seeds are tiny seeds or metal beads attached to an adhesive and placed on pressure points in the ear. They're brilliant for calming the mind, easing anxiety, and restoring balance. We use them in our clinics all the time. Head to acupips.com to find out more and use the code RELAX for 20% off. Today, I am with Claire Mooney. Claire is a consultant and the clinical director of Fertility Solutions. Claire specialises in male fertility and she started the company with Professor Jonathan Ramsey to provide better testing and treatments for male fertility to hopefully improve chances of a natural conception or increase the odds of using assisted conception if you end up going down that route. So Claire, welcome back to the show. Today we are going to be talking about double-stranded DNA breaks. Have I pronounced that correctly?
Perfectly.
Great, that's always a good start. So can you, before we get into that, can you just say a little bit about your background and the work that you do?
So basically, my background is 30 years now in fertility, both IVF and male fertility. And I started in 1995 and I stumbled into it really because I was doing a research project at Liverpool University and I couldn't find anything that I wanted to do. I was struggling to, I suppose, gain an interest and really know what I wanted to do. And I found my way to Liverpool Women's Hospital. I met Ewan Lewis Jones, a wonderful man, who said, "Oh, we've got a Hobson sperm tracker here. We don't know how to use it. If you find out how to use it, you're in. You can do a research project on human sperm." And I thought how amazing that sounded. So I looked into the differences in swimming patterns, loved it, just fell in love with it, just became quite obsessed with it, I suppose. And then I did a master's degree and kind of, carried on with my sperm work through research. And then I found my way into IVF. And that's what does happen in this sort of way. It sort of happens that you find your way into an IVF clinic because essentially, even back then, well, especially back then, there wasn't specialist male fertility clinics. There wasn't. What I wanted to do didn't exist. So I ended up in an IVF clinic. I did love it and met some wonderful people and ran and, worked my way up the ladder to consultant level and had a fantastic sort of 10, 20 years in that world. But what really bothered me and what always bothered me was the lack of success and the lack of science in a lot of ways as well. So the lack of pregnancy and live birth. And it wasn't my passion. My passion was male fertility. And very much in an IVF setting, it's about preparing sperm rather than diagnosing the man. And so I struggled with that. And about 13 years ago, my brothers entered, I don't know if I've ever told you this actually, Hannah, but one of my brothers entered the fertility world. And it kind of really tipped me over a little bit because I could see what was going on with my brother. I knew why he was struggling with his fertility. I'd still kept up to date with everything male fertility. So I set up Fertility Solutions. And it really was all about kind of not just providing tests to men, but also understanding why they needed those tests, how those tests were gonna help them, how the couple was gonna integrate that information together. I met Jonathan Ramsey, Professor Ramsey now, about 30 years ago when I first was a junior embryologist. And then I kind of stumbled into his Windsor clinic, started doing work with him and just everything just snowballed really. But I really was going back to my roots, back to what I actually really was completely fundamentally fascinated by. Because during my IVF journey, I was just perplexed by the lack of success, even for very young people. And for me, anything that's only 20% successful isn't that successful. And I suppose I'm very scientific. I like things to be very scientific. So I want to understand why my patients are not conceiving naturally. Why are they not conceiving with IVF treatment? And I was quite surprised, I suppose, by how that was lacking in the IVF world. It was all about one size fits all. Everybody has IVF treatment, regardless of the reason that you're there. IVF treatment was set up in the 1970s by Patrick Steptoe and Bob Edwards, and they basically invented it for people with blocked fallopian tubes, which it still remains a very successful treatment for. So for me, I just loved male fertility. I love the sperm. It's a very different concept to be when a woman is born, she's born with all of her eggs, and the eggs slowly genetically deteriorate over time. But sperm aren't like that. Sperm are constantly replenished, constantly made. And I personally, Hannah, think that the IVF and the fertility industry is backwards. I think that you should start with the gentleman, with the sperm, with the partner that is producing sperm. And I think that's where we're going wrong a lot of the times, because yes, you need to investigate the female fertility, and I think fertility clinics still do that relatively well, although that could also probably be a bit better as well. But the man goes into a fertility environment. NHS usually has a semen analysis, and semen analysis is not the best test for defining whether a man is fertile. It's a test, and it's a test you should all have, men should have, but it's really a test about once the sperm are there and they're being produced. I think that a lot of interpretation of semen analysis is done wrongly, because it's very much a matter of, well, you're making sperm, so everything must be okay. I think that semen analysis provides us with a very basic level of understanding of a man's fertility. And the actual statistic really is around it's something like 60% of men with a normal semen analysis are profoundly suffering from infertility. So when we look at that statistic, we know that everything is being done backwards, incompletely. And there's the other sort of parameter I always struggled with was the undiagnosed, unexplained infertility couples. I always found that very difficult, because that was almost like a diagnosis on the forms that you fill in as an embryologist. You tick unexplained as a diagnosis. I couldn't help but feel that's not a diagnosis. That's just a fact. It should be undiagnosed. We have not diagnosed this couple, and I think that when you look at data, the unexplained, undiagnosed couples are probably the couples that do the worst when it comes to IVF treatment, because IVF treatment almost relies exclusively on the kind of, I suppose, onus that all fertility problems are because egg and sperm are not meeting. But that isn't the truth. That isn't the case. So if we look at the number of patients that have tubal factor infertility, that are actually diagnosed with blocked fallopian tubes on the NHS, it's very low. It's less than 10%, Hannah. Less than 10%. So less than 10% of people have blocked fallopian tubes. So 90% of people don't. And yet we still have at least 40% of people that have this tag of unexplained infertility. So it's not unexplained. You just haven't been diagnosed. So that's where I want the change to happen. I am absolutely all for testing, but I'm far more about diagnosis, pathways, actually finding a way to what this means for you. And so is Professor Ramsey. So Professor Ramsey has been in the industry now for 50 plus years. He's exceptional, and he is constantly researching. So what we're seeing in the last few years, so I set up Fertility Solutions in 2013. Yeah, gosh, yes. So what we're seeing now, the biggest change that we're seeing is that we are now seeing more research, more people coming to look for answers. And that's down to people like you, Hannah, actually providing the information, this amazing platform that is your podcast, and social media. I'm not a great fan of social media. I suppose I'm 52. I'm not of that generation, but I can totally see the power of it coming into everyone's living rooms. In the old days, we'd have to go on TV, take out a massive amount of money for an advert, hope that someone saw it. But nowadays, of course, you can go onto things like this and listen to it. And you've got lots of experts on here that are, at the top of their game, of their field, that are giving information. And that's what inspires me at my age now. It inspires me that finally we don't have a shut door and the doors are opening, and we're now seeing a lot more people getting answers as to why they haven't conceived. And it's very exciting for me. And I suppose right now, even though I've been doing this for 30 years, I feel like a teenager almost sometimes, because we're in the first flourish of what I had hoped the industry would be like when I was 22.
Mm.
And it is. We're seeing things we're going to be talking about today. I think this is the first podcast that's talking about this outside of Professor Ramsey. And we're seeing lots of other things that are happening in the male fertility world as well, like sperm swimming patterns, i.e., they're not just swimming, they're swimming X in an X kind of way. Cell-free DNA, where we're seeing more and more research into how little bits of DNA in seminal plasma could have a huge effect on what's going on. So we have to stop thinking of sperm as wiggly little tadpoles. And once the tadpole has been ejaculated, processed, and is in the lab, we've got it. Beautiful. No, wrong. Just because the tadpole is there doesn't mean it functions. So the sperm, sorry, everybody, just doesn't mean it functions properly, doesn't mean it has genetic coding inside it that can make an embryo, doesn't mean that the seminal plasma surrounding it isn't affecting everything. So we know that fertility is not basic. You would never have something significantly wrong with your body and not investigate it, and just have one blanket treatment for all. There's very few areas of medicine that are like that. So we are now catching up hugely. There's a lot of catch up that's going on, and there's a lot of change that's happening. I mean, so much so that we have to regularly sort of. I mean, I've never had. We have a quality control manager now, and she's quite got the biggest job of rewriting everything and explaining everything to people. But anyway, so essentially that's us, and Fertility Solutions is not a just not so much a testing center. It does do the tests, but we are now moving on far more into the pathways, and we are one of the only independent fertility clinics in the world. So we have the ability to say this is what you need to do and this is who you need to do it with.
Mm.
So it's exciting for me. Every day is exciting.
So we have met before and spoken about DNA fragmentation,
Mm.
and we've done a podcast on it. But today we are going to talk about double-stranded DNA fragmentation.
Yeah.
So can you tell us first of all, what is DNA fragmentation and what is double-stranded DNA fragmentation, please?
Brilliant. So every sperm has DNA inside it. A sperm is DNA with a tail. Its entire reason for being is to get the man's genetic material into his partner's egg. And inside the sperm head is DNA. I'd like you to imagine DNA as a ladder, Hannah. I think that's the easiest way to describe it. Now, what we know is that DNA can have breaks in it. And so the sperm can be present. Remember, I said to you about the wigglies being there, but you need to really understand what's going on inside the sperm, which is far more fundamental. So DNA is fundamental to everything. Code of life, the embryo's ability to create, to fertilize, the egg's ability to fertilize, the embryo's ability to develop into an embryo that will be a baby for you. Now, half of that baby comes from the sperm's DNA. Now, inside the DNA, if you imagine it like a ladder, I suppose single DNA fragmentation relates to the breakages within the ladder itself. So we know that DNA, obviously, is better when it's more integral and made well and has all the coding going on within it. But the more breakages you have in that coding, the more damaged the sperm might be, the less able the sperm will be to contribute to the message to make the embryo. Now, if you imagine that single stranded breaks, let's go back to our ladder, is breakages in the rung outside the middle. Double stranded is when the ladder snaps. So you've got two pieces of ladder. And they are far more significant potentially, Hannah, because when you have lots of little breakages in the DNA, the egg has a very amazing ability to repair DNA. So, embryogenesis is when the sperm enters the egg, fertilizes the egg, and the egg starts to develop into an embryo. Now, the actual method of making the embryo is called embryogenesis, and the egg has the ability to repair damage. Now, when you're in terms of repairing the damage, it becomes a lot harder to repair snaps in the ladder. I mean, imagine it yourself, and if we go back to a ladder analogy, it's probably a lot easier to, put the ladder back together again, put the rung back in again, than it is to try and cement the ladder back together again. And that's what double-stranded breaks are. And I suppose we're understanding more and more about this situation now and how some people with seemingly low DNA fragmentation damage, if it's double-stranded breaks that predominate that damage, it's more significant, or it could be more significant for the couple. So that's what double-stranded breaks are. There's only actually one test that looks for that at the moment. It's called a neutral comet test that looks for the double-stranded breaks. So obviously, there's only one clinic that's doing it at the moment, so there are cost implications for patients. So it
Yeah.
will be important to talk about sort of when and when not to do all these things, I think.
Okay. So, before we go into that, do we have any data or information about how this double stranded DNA
Oh,
fragmentation impacts fertilization,
yeah,
embryo, miscarriage,
absolutely.
pregnancy loss? Do we know what happens?
Well, the data is emerging. So we've just had a paper accepted at Fertility Solutions. We work very closely actually with the clinic that does double-stranded break testing, Examine. In fact, we probably had the longest standing relationship with them of all clinics. I met Sheena Lewis back in about 10 years ago when she set up Examine, and I now know Professor Tara Moore very well. And by working together, that's what also has been lacking throughout the ages, data, actually
Mm.
how these strands actually relate to what happens to patients. So essentially fertilization occurs. I don't think I don't think we see a lack of fertilization when you have double-stranded breaks because for fertilization to occur, the sperm needs to be able to swim, penetrate the egg. Obviously, there are problems with fertilization that don't relate to double-stranded breakages, but I don't think fertilization is predominantly affected. It's more the embryo when it starts to divide and when the sperm genes start to turn on, which is at the 4 to 8 cell stage in the embryo. So the damage happens sort of during embryo division. You see embryos stop dividing. You see them not get to blastocyst very easily. You see a situation where you had lots of eggs. This is in an IVF situation where you had lots of eggs. You had quite good fertilization. You had then the embryos tended to go okay until the 4 to 8 cell stage, then they slowed down. Some of them stopped developing, and also what we know with this is it's like very much DNA breakage in total. You have a higher chance of miscarriage as well because it's all about the inability of the embryo to code properly for the baby to be able to develop properly and to go to a full-term birth. So I suppose when we see double-stranded breaks, we see it in recurrent miscarriage, IVF failure, when we've got loads of embryos that are not getting to the blastocyst stage. And that problem becomes compounded, Hannah, I think, more and more as women get older as well, because the egg loses the ability to repair the sperm DNA, if that makes sense. So yeah, so that's basically what we see when people have double-stranded breaks.
So it sounds like in terms of fertility outcomes,
Mm.
double-stranded DNA breaks is going to have a greater impact on a person's ability to conceive than single-stranded? Or is
That's
it
what the
very dependent on the age of the female,
mm. So
all
these
the other
are
factors that impact a fertility picture?
these are questions that are being constantly asked. So essentially, right now, we have a real lack of data in general, but we probably have about 4 or 5 papers now that have been accepted to human reproduction that are being looked at, that we're understanding this in more detail. So double stranded breaks is something that we started routinely doing in Beaconsfield about 2.5 years ago. And it's gained traction. I'd say in the last year we've done more and more. So the data is increasing. The data is something that is constantly coming up. But I think that what Professor Ramsey thinks, and I think it's a very good way to go really in this world, is that breakages can be there. They can sometimes be there at low levels, but if they're double-stranded breaks, it has more of an effect on the embryo, the ability of the embryo to create a live birth. And I think that what's important is that we remember that essentially there is a whole pattern here. So if a woman is sort of under the age of 30, under the age of 32, her eggs have much more of an ability to repair damage. But when you're over that age, your eggs are losing that ability to repair damage. And that's just natural. That's just an effect of aging and time. So it's very much what we need to avoid is what has been done wrongly for so long, which is a blanket policy, a blanket testing. So I'm not suggesting to your wonderful listeners that they all go and have a double-stranded break test at this point. It's expensive. It's £600 to £800 because it's done by one clinic, and it does take that clinic a long time to do it. To be fair to them, they're not profiteering. It takes absolutely ages to do that test. So I'm not suggesting a blanket sort of testing for everybody because I don't think that it's always necessary. But if you are in a situation whereby you've had multiple, more than one cycle of IVF, the fertilization rate was fine, but the embryos didn't develop well. If you've had a miscarriage or suffered multiple miscarriages naturally, if you have a real unexplained, undiagnosed process going on over years of investigation, then I think it would be sensible to have this test done. I mean, obviously, there's an ideal scenario here, Hannah, which I would like to see. I won't see it in my career. I've accepted that now, that the NHS actually does all of these tests at the very beginning of a man's journey. So they send a woman for some hormone testing, scanning. They need to send a man for scanning, hormone testing. They need to do a semen analysis, a fragmentation test, a microbiome test, which we'll get on to as well, and just help couples to understand why they haven't conceived. Now, the NHS, as we all know, is strapped of money. They leave you waiting for 6 to 10 months, well, 6 to 18 months for referral. But what they should be doing is rather than sending you towards an IVF pathway, by the way, I know I sound very much like I'm very anti IVF. I'm not actually. I actually think that IVF clinics are very important. They have an important part to play here, and that there are lots of people out there that would never have had children without them. So, although we are trying to help people get pregnant naturally, we totally accept that IVF is, fundamental to this as well. So, in terms of sort of the next sort of process when you're I suppose when you're sort of looking at all of this from start to finish, it's all about understanding what's actually happened to you. What is your story? What is actually happening? Have you got a diagnosis? Have you been told why you can't conceive? And obviously the NHS usually only fund one cycle of IVF treatment. So it would be very important for them to properly diagnose patients first. Because if you have tubal factor infertility, low levels of damage, no microbes anywhere, great. You've probably got not a 20% chance of live birth, but you've probably got a 50% chance of live birth. Also, fertility treatment should be viewed very much not just in terms of what it actually is treating, but what it can do. So I think IVF treatment is fantastic for fertility preservation, family creation. So really thinking about if you're 35 and met the love of your life, you want to have children and it's just struggling and then you get diagnosed. Fertility treatments can be very helpful for preserving your ability to have a whole family, because as we know, you have a baby at 35, you're never ready again till you're 38 or 37. And then, time factors are really sort of kicking in. So I think that why I'm so excited at the moment, why I can barely sleep, why I've got these bags under my eyes right now, is because we are in a situation whereby we have the real ability to diagnose, treat, give people the right treatment, and give people the options to preserve their fertility. And obviously, there are different ways of processing sperm within an IVF environment that can be really helpful for double stranded breaks. So, I am not against IVF treatment, far from it. I want a more collaborative pathway between clinics that are diagnosing, clinics that are treating. And as I say, some of the best IVF clinics are fundamental to patients' journey. There are lots of clinics that are doing genetic analysis of embryos. Those embryos don't implant. I think, personally, from looking at the data, that a lot of embryos that don't implant, that are euploid, genetically normal, have double stranded breaks.
Mm.
Because what we also know is that you can have a normal number of chromosomes in your egg, in your embryo, but you can also have a fundamental inability of that blueprint to create a baby, an embryo, a pregnancy, a live birth. And that's where double stranded breaks come into this as well. But we are actually doing some very exciting stuff at the moment with people like Professor Tet Yap, amazing gentleman, Jazz Kelsey, Professor Ramsey, where we're looking at all of the ways in which sperm could be prepared in an IVF environment to lower the double stranded breaks. Because I don't think you should ever do a test unless you know what you're going to do after it.
Mm.
I don't like over testing. But once we do a test, we need to know, how is it going to change the clinical pathway for the patients? So, how is doing a double stranded break going to change your outcome as a patient? And it might be that you have double stranded breaks, and we say to you, do you know what? Ironically, after years of, saying to people that IVF is done too much, you might need to have fertility treatment so that the sperm can be processed in a way that lowers the fragmentation, the double stranded fragmentational breaks. Now, obviously, there are the usual factors. Everybody should be thinking about reducing their BMI, obviously, smoking, cannabis use, taking supplementary testosterone. Hannah, I am seeing a massive increase in gentlemen that are doing this for their mood, for their mental health. But artificial testosterone affects the ability of DNA to be created properly in sperm. So, that's something that needs to be obviously looked after as well, which goes back to the urologist and the urologist's involvement in all of this. So, what the fertility clinics can do, game changer, is
Mm.
to employ 1 to 2 urologists in every single clinic, and the urology team sees the gentleman. Are you taking testosterone? Are you taking finasteride? Are you taking steroids? Could you lose some weight, please, sir? Could you exercise more accurately? Could you lower your testicular temperature? All the things that we could do from the beginning of the journey, not the middle or the end. Because if you start trying to have a baby at 35, by the time you get to, I don't know, baby number 2, you're 40 sometimes. And that changes things for patients as well. So I want to see a pathway process whereby a urologist gets involved, a gynecologist gets involved, and then the IVF clinics absolutely get involved as well. And it might actually be, ironically, as I say, after years of, me being concerned about it, that actually IVF treatment with specific sperm processing, it's called sperm microfluids, where you basically send sperm through slides. I'm not going to name any brands at this point either, because there are more brands coming out, and I don't like how expensive these slides are becoming. So I'm not going to name brands. We all know who we're talking about. But there are other people that are developing these slides now as well. And the sperm swim through the slides, up through membranes. And these membranes and the slides mimic better pathways within the female body. And what we're seeing, and what Professor Yap's new paper is showing, is that essentially when sperm is processed, then the double stranded breaks come down. So even when all of the breaks don't come down, the double-stranded breaks come down. Not for everybody when we're gaining data. So there is an absolute need for a circle, a Venn diagram almost, male, female, together,
Mm,
right pathway for patients. So I mean, absolutely, the first line pathway is lifestyle factors. You can have your coffee, gentlemen. I don't really believe in the caffeine thing, but don't drink, don't
mm,
smoke, don't take cannabis, please, please. Don't take testosterone replacement therapies. Don't don't immerse your testicles in hot environments. I mean, obviously, I'm not talking about getting on a Boris bike in London for 10 minutes, but lifestyle factors are important. I'm also seeing a huge number of I don't know, supplements that are coming out that seem quite random. Stick to Proxy, stick to Impril, stick to things that have data behind them. And then, of course, there's the absolute need for the reduction of inflammation and the reduction of cortisol. And that's where acupuncture, reflexology, and nutritional factors come in as well. So what we need is a Venn diagram of all situations, diagnosing, talking together, and then setting out the perfect treatment pathway with the goal of natural conception, of course. I think that
mm.
a lot of people that have IVF treatment could have conceived naturally and would have done. But if you are having fertility treatment, the one cycle that the NHS funds, maximize it,
Yeah.
optimize yourselves, get fit for fertility, have some acupuncture, sort out your diet, lower your BMI, follow pathways whereby you're optimizing your body's. So if you imagine testicles as a factory, chaps, that's what they are. They're an amazing factory making millions of sperm, 40,000 sperm in the average half an hour conversation I have with chaps. So the factory is only part of you, and the factory is making DNA. Your children are being made in your testicles. Now, that is a huge, important factor to think about. These are potential children that are being made all the time over the 3-month period. So, optimizing everything as you're heading towards fertility treatment, as you're heading towards any kind of treatment, is where we should be. I mean, unfortunately, there's evidence now to suggest that there is fragmentation levels increase as a man gets older as well. So it might actually be that I'm not suggesting that everybody goes out there and freezes their sperm who's 25 right now. But I do think also, Hannah, that we should be thinking about potentially freezing sperm when a man is in his early 30s. Because I think personally that DNA, that there is a biological sort of clock, if you like, to sperm as well, i.e., the testicle loses the ability to function optimally. We see lots of fragmentation levels start to go up after the man reaches about 43, 45. So it's about thinking about how do we optimize this for the couple for the future?
What was interesting at the fertility conference was the emphasis was really on male factor,
Mm,
and B, this theory around using semen analysis or sperm health as a predictor of male
mm,
health.
mm.
And often we talk about these things in isolation, don't we? Of fertility and the ability to conceive. But really, it's that wider conversation around health and around lifestyle and impacts of microplastics and
Mhm.
all of these factors that play such a huge part in, yes, your sperm, but also your health, and therefore your longevity. So
Agreed.
it's like a wider conversation, isn't it? All of this information
We
about male health.
Absolutely. We diagnose people with testicular cancer, not very often, but we do. We diagnose them with prostatitis, prostate cancer, diabetes, congenital absence of the vas, so genetic issues as well that have significant effects on them later on in their lives. So, absolutely, Hannah, we are missing a massive factor in terms of men's health. The answer of, well, that's okay, we'll put some sperm in an egg for you, and not understand why your factory isn't making sperm at the right density, at the right numbers, is old fashioned and
Mm,
inappropriate and not
mm,
good healthcare either. I mean, I think, I mean, I'm obviously this is my 13th year now, and I'm seeing a growing number of clinics and tests and online this and online that and AI as well. I would just say that it's really important to understand that, I mean, I appreciate that AI is coming into this. My father-in-law cracked his ribs skiing last week, and he's using AI to diagnose himself. I'm like, Paul, you could be dying, could be bleeding to death right now. But ultimately, I think we need to be very careful about AI. That's what I would like to say actually as well. And it's because it's going to lag massively behind everything. Because at the moment, I mean, we are writing lots of articles for AI, but if you put your results into AI more than once, you'll see that you'll get a different answer depending on how you word it and how you sort of present it. So what we need is really good information, good sort of, diagnostics, good pathways, clinics that do that. Try and find a specialist clinic that isn't completely, isn't, so I suppose, going to put you down the IVF route straight away. I mean, there are probably a handful of urologists at the moment in the UK, probably less than 20 that are top level fertility urologists. Careful when you choose one because some of them are quite general. I mean, it was good to see more male fertility stuff at the show. I wanted a lot more though, Hannah. I mean,
Mm.
for me, it's still being debated. DNA fragmentation is still being debated at the moment by nice guidelines, as we know, by other clinics saying, "Oh no, we'll just do ICSI." Well, the reason I know fundamentally that if you just do ICSI, it's not gonna help. Is that if it was gonna help, you would have seen a huge increase in the live birth rate in 1997, which is where ICSI started to really go exponential in the States. You didn't see that. You didn't see any increase whatsoever, which tells you that ICSI is not the universal answer to fertility problems at all. The universal answer to any problem with your body is to find out what's wrong with it.
Mm.
Get somebody who knows what they're talking about to help you. AI is not that person at the moment. Might be in the future. We'll do lots more information. I'm not against AI. I know everybody's going to be like, oh, we're going to put you out of a job. I'd quite like to be out of a job. That would not be a problem for me at all right now. That would be a success. But at the moment, just be careful about it because it doesn't I actually tested it this morning to see how much it knew. It knows a little bit. It knows a little bit about cell-free DNA. It knows a little bit about microfluid chambers, but it doesn't know a lot because, of course, all this is still happening at the moment.
So, with double stranded DNA fragmentation, if you have high levels of standard DNA fragmentation,
Yeah.
is there a link then or is that an indicator that you're more likely to have double stranded breaks? Or is it separate?
It's a really good question. Still being investigated.
Yeah.
I suppose hot off the press is that I think there probably is an association. I'm not saying that everybody that listens to this podcast needs to go and have a double stranded break test. They're expensive and really careful how they're interpreted because I would say there's only I'm gonna say something controversial. I'd say there's only 4 people that really know how to interpret double-stranded break tests right now in the UK. So, very careful if you're having that test done that you're under someone like Professor Ramsey, Professor Tek Yap, Jazz Kelsey at Fertility Solutions, Andrology Solutions. Just make sure that you're under a clinic that is absolutely abreast of all the latest thinking on everything. But I think that there is absolutely going to be an association there, yes. I think what we can't rely on at the moment is that the word normal. This is what you have to be very careful about, the word normal. So we are setting thresholds for DNA fragmentation, double-stranded breaks. Professor Ramsey is pretty much doing that at the moment. I think we have to be careful about the word normal. You know, we've been too free with it with semen analysis. We need to be very careful we don't do the same thing with double stranded, single stranded break tests because what you need, and this is what I always say, and I'm never going to change my mind on this because it all comes back to this. You need a urologist. You need a urologist that understands all of this to say, okay, here's this result, here's that result, see you. How does it relate together? Because also, of course, you've got the microbiome in there as well. You've got lots of people now having male and female microbiome tests. sometimes going to their GP and saying, "What do you think?" The GP says, "Here's a load of antibiotics. Good luck with that one." That won't work. I can tell you now that that is the worst thing you can do, is to take a load of antibiotics if you have any raised microbes from a male and female perspective. You can cause yourself to be completely unbalanced. I think what's growing at the moment, and what Prof is also responsible for, is more of a seminal vaginal ecosystem. I think that that is going to be where we're going next. Understanding that male microbiome and female microbiome, so microbes in your semen, microbes in your vagina, how they interact together. You're having intercourse to create a baby, so of course they're going to mix, and how they have an effect on your double stranded breaks, how they have an effect on your seminal environment. So that's something that needs very specialist handling, because vaginal microbiome, male microbiome, how they interact together, what they actually mean is super important. I mean, yes, antibiotics can be prescribed, probiotics can be prescribed, but again, it's then relating it to all the test results that you're seeing. I mean, I don't really want to see a situation, I don't think, where people go out and do all the tests and then bring them to me for interpretation, although I can see that happening, because that's expensive and you might not need a lot of those tests as well. It's really about sort of knowing which tests you need, getting a consultation with a clinic that goes, "Well, hang on a minute, what's going on? How many embryos did you get? How many eggs? What's your AMH? What's your partner's age? What's your semen parameters been like throughout your life? Are you overweight? Do you smoke? Do you drink? Do you take cannabis, cheeky cannabis or anything like that? Are you busy taking a bit of testosterone because you're feeling low?" As so many people are after COVID and
Mm,
everything. What is actually happening for you? Do you need a double-stranded break test or not? So I think I mean, maybe I'm old-fashioned when I say this, but at the moment, I haven't seen any AI software that helps you do that at the moment.
mm.
Maybe there will be in the future, but at the moment, nothing will compensate for a good old-fashioned sit down, full assessment of what's going on with you, your partner, and how they interact together, and then really good advice from the beginning of the journey if possible.
When we talk about single stranded DNA, we often talk about lifestyle factors and everything that you've mentioned about cleaning up your life, about looking at the microbiome, about losing weight. And it can really have an impact on the
Well,
outcome. Do you see the same with double stranded DNA? So is there a link between the lifestyle and the external,
yeah,
or are we talking about something that's happening
fundamental.
on a deeper level in the human body?
So again, everybody's different. Everybody's aspect of this is different. But yes, there are some patients that have fundamental problems with testicular function, with the ability of the testicles to make the sperm, with the epididymis that creates the motility, with issues within that environment as well. There are some patients that may need to have interventions, testicular biopsies to lower the fragmentation. There are patients that may need to have this IVF treatment with microfluid chambers that lower DNA, double stranded DNA breaks. There are some patients that will be diagnosed with genetic translocations and issues that are fundamental to their fertility. And there are some people, Hannah, and this is why you have to be so careful with this test. There are some patients that will be told by prof, either of the profs, that you may need to use donor sperm. That is a fact.
Mm,
You may actually have something fundamental that is happening in your body that means that the fragmentation levels can't be lowered. Now, at Fertility Solutions, we basically make sure that this microfluid chambers do lower double-stranded breaks, so Professor Ramsey doesn't send people into the abyss with a, "Well, let's hope it's okay." He actually does make sure that the fragmentation levels, double-stranded breaks, are lowered, and that's called in our clinic, it's called a Zymot test, and it's where you make sure that this chamber does actually lower the double-stranded breaks. It does actually lower the single-stranded breaks for you, because there are some patients it doesn't work for. There are some patients, because again, you have with a euploid embryo a 60 to 70% chance of implantation. That means you have a 30% chance that the embryo doesn't implant. So there are lots of environmental factors there as well. We mustn't forget the female partner in all of this. There are inflammation issues, endometriosis, endometrial issues. There are immunological factors in the woman's body that will be affecting things as well. So, yes, fundamentally, to answer your question, there will be some patients where we can't do anything, but they are still in the minority. They are still in the minority. Again, going back to what I was saying before, don't do a test if you can't do something about it. So, if, for example, we're finding that double-stranded breaks were you couldn't lower them, you couldn't change it, we wouldn't do it. There are lots of IVF clinics out there with very good pregnancy rates that are doing an excellent job in the laboratory. But then when it comes down to it, fundamentally, the embryos are not implanting, the embryos are not creating a live birth, and they're having multiple cycles of IVF. I would definitely say to everybody, I would stop after the second cycle fails. Stop. Because I don't like the word luck, bad
Mm.
luck. Now, obviously, you can be lucky in life, lottery, that's not going to happen, by the way. Get struck by lightning 10 times in your garden, more likely to be. But ultimately, we need to stop using the word bad luck when your IVF cycle fails. Because when you're having IVF treatment or treatment of any kind, you're trying to take the luck out of it. You're trying to take the luck away. If you have a heart transplant and your heart was failing, you're not going to hope that your heart just suddenly starts beating again. You're taking the luck factor away. That's what science is. That's what good scientific practice is. So even though there are, I think the situation of very few people in the industry with knowledge is changing. I think that is fundamentally changing. It's changing rather slowly, but it is changing. So there are people out there, as I say, mentioned Professor Tet Yap and Jazz Kelsey, Professor Jonathan Ramsey, Sux Minhas that know basically about double-stranded breaks and how it affects things. I think more fertility clinics are coming on board, Hannah. I've seen in the last 2 or 3 weeks, for the first time ever, fertility clinics referring patients to us for double-stranded breaks, which is
Mm.
honestly, I mean, so, like, one of those heart things,
Yeah.
just because it's about working together. The most important person in this is the patient,
Mm.
the future baby of the patient, and that is something that I would love to see to continue to change. This closed door culture of, well, you come here, you sign a disclosure, you're not having any other treatment, end of. That
Mm.
really fundamentally needs to change, and it is changing. And you're changing it. People like you with this are changing it because before you and others, there was no information like this. Professor Ramsey, I mean, he's been on multiple talks, multiple shows. There are lots of organizations out there, Test Him and clinics like that are changing things fundamentally. So it's very exciting at 52, to be maybe in the last 10 years of my career to be watching things finally go how they should have been when I was 22.
Mm.
22-year-old me would be very happy right now. I'd like to look like
So
22-year-old me.
so, before we finish up, I guess what I'd like to just reiterate, because it is the thing that people get confused about,
Mm,
is at what point should somebody think about doing this test? So, what are the kind of red flags for a person's fertility where you'd start thinking, we don't just need to do DNA fragmentation, we need to think about this double stranded break?
mm. I mean, they're all tied in together. If you're really young and you're being told you've got no cause of infertility, I'd start thinking about having more testing done. In terms of double-stranded breaks itself, obviously, Hannah, this is part 1 of this podcast. Part 2, I think, will be as soon as December because that's how fast it's all moving. But I think that if you've had a cycle of IVF that didn't work, you've had more than 2 miscarriages, and you're under the age of 35, or let's say under the age of 40, if your partner has a urological history of some sort, undescended testicles, a varicocele, any kind of genetic factors that have been diagnosed. I mean, obviously, if your partner is smoking cannabis and drinking alcohol, taking testosterone replacement therapy, um, it's all very easy for someone like me to say he needs to stop that, but he does need to stop that because he should be thinking about it not in terms of getting you pregnant, but he should be thinking about it in terms of his child's health going forward. Because there are other aspects of here that, are uncomfortable to think about. But the biggest amount of data that doesn't exist because no one ever looks at it is the children in these situations. So there's very little data, if any at all, on the outcomes of young people, teenagers, and then their chances of conception when a man has high fragmentation in his sperm as well. So
Mm.
there's epigenetics here as well, not just the ability of the sperm DNA to code, but also its ability to function properly. And a lot of the time, we don't really see things like genomic imprinting coming into situations until we are much older in life. So we should be all thinking about the future health of our children, not just having children at this point as well. So, I mean, obviously, get a consultation with an andrologist or a urologist that specializes in all of this. Reach out to us if you want to. We can advise you. Um, we don't like to overtest. I would have to say that the double standard break tests that I've done are still under 40 in the last 2 years because I don't like to jump in too quickly when I can see that actually it's less likely that that's the case. Um, and our pregnancy rates with natural conception are as high as any IVF clinic when you actually diagnose what's wrong with somebody. We also work very closely with a lovely lady who you've had on, Lynn Chapman, who's, a pioneer, in my opinion, in fertility because she is actually saying, do you know what? I'm not going to try and investigate the male side. I'm going to let people like Professor Ramsey do that. So, I mean, I suppose don't jump into having it too quickly. It's 700 quid all day long, done properly. I would say take your time, have a consultation, understand if that's something you do actually need to do, and get a diagnosis. If you
Mm.
haven't got a diagnosis, then it should be considered. If you really don't have a diagnosis, if everything is looking absolutely spot on from a male and female perspective, then it might be a good idea to have a double stranded break test. But the data is still being collected. So we have data on our association with Dr. Chapman, which is extremely positive at the moment, But when you look at the male side, our IVF ladies that have IVF with Dr. Chapman, it's not 20% for them, it's more like 62% for them.
Mm.
So just, I suppose, yes, use a little bit of Google and ChatGPT, but really seek to get a diagnosis from your clinician. That's what
Yeah.
you can do. That's what you should do.
Lovely. Thank you, as always, Claire. It's been
Loved it.
fascinating to talk about it, and I'm sure we will meet again to discuss it in more detail because I know it is an ever changing world. And I feel
Oh, we haven't
like,
even touched on like sperm swimming patterns, Hannah.
yeah,
Happening at the moment, cell-free DNA. But the best thing we can do, I think, is, as you say, is podcast when we know
yeah.
what the outcomes are. Yeah.
Yeah. And also what is clear is that male fertility is not getting better. It is going down all the time, quite dramatically. So the more we can talk about it and think about it and think about it in a wider picture, the more we can try and address that because it's still an unexplained really as to why male fertility is on such a huge decline.
It's interesting, isn't it? I mean, I don't want to say too much about politics, Hannah. I could never have been a politician. I think it's the worst job in the world, the most underappreciated job in the world. But I think that we have a real habit as humans of doing something when it's on our front doorstep and not doing something until it has. I mean, I did a zoology degree in 1995. Professor Began, who was a leading environmentalist at that time, sat us all down one afternoon and said, guess what, guys? In the year 2024, if you haven't changed what you're doing, we'll be in a situation with climate change where it won't change and it will be something that we can't change and we'll have to just live with it and it will get worse and worse and worse. Hotter summers, colder winters, wetter winters. And he was right. Professor
Mm,
was totally on the money.
yeah.
I don't think that people do things until it's on their doorstep.
Yeah.
So I think that the government, personally, this is my prediction, is that I think that our government will probably start to investigate male fertility hugely when we get to a stage where we are seeing we're in a declining birth rate at the moment in the
Yeah,
UK, but that's because of social economic reasons, we think. But if we get into a child of men situation, Handmaid's Tale situation, whereby suddenly we see a massive reduction in fertility, that's when people will step in. And I don't know
yeah,
if it will be too late. I mean, hopefully it won't be by then, but the environment we're living in is a very strange one, a very
yeah,
artificial one. But I
yeah.
think people are changing though, don't you? I rarely speak to young people that smoke actually these days. I rarely, oh, do you speak to more people that smoke? You
Yeah,
do?
yeah,
People are not
yeah.
telling me that they're smoking. Maybe I go, "Do you smoke?" And they go, "No." I've been told
Ye
I'm not very approachable. Oh dear.
Well, thank you, Claire, as always. It's a pleasure. I know you'll be back soon, and I will put all the details, of Fertility Solutions and everywhere you mentioned
Thank
on
you.
the show notes so people can access that. And I will see you again.
Amazing, Hannah. Take care.
We hope you have found this helpful. If you'd like more on fertility education, please see our Teaching to Conceive free course linked at the end of the show. You'll also find the link to join our community. For more personalised fertility support, you can work with us one-to-one in clinic and online. You can book a discovery call to find out more.